Welcome, everyone. Glad to see you this morning. The topic for this session is shared wisdom, insights from Mito patients at different stages of the journey. And I want to talk to you a little bit about the goals of our session are to make sure that the attendees have practical knowledge, strategies, and resources to navigate like key transitions in the Mito journey, whether it's moving from pediatric to adult care, managing legal and financial preparations, a strong network, understanding what interventions are out there. We hope you leave with practical information and a shared connectedness with this group. I want this group to be somewhat interactive. We're going to be together for a couple hours, and I'm really excited for you to hear our panelists' stories and the information that they're sharing. We created this session because we realized that many of you are going through journeys that others have gone through before. And it makes full sense for you to get that information so that somebody that's been there before can walk you through what's coming next. You're not recreating the wheel here. There are others that have been there and you're not alone. And that's the message that I hope we get through today. So some of the other things that we thought were really important is understanding what's again, the next stages. What happens after you leave kindergarten? What happens when you go to college? All of those things we're going to touch on a little bit today, but also the emotions that tied to all of these changes that are happening in your life. So I guess we're on the speakers page now. Should it be working for me? Or are you going to bring me a new one? Oh, I think it's. Let's see. Okay, I think we're talking now. So as we launch into this, I will tell you that later in the presentation, we're going to provide you with a one-page handout that will include tips that I've been collecting over the last couple of months from our UMDF support ambassadors, things that they thought were important in their journey and want to share with you as a group. We will probably hold questions to the second half because we have some time to really get together in small groups and kind of have some conversations. But if there's anything pressing during any of this, please raise your hand. We have mics that I can detach and bring over to you. So we're going to get started with the diagnostic journey. And this is something that obviously you're here because you've already been through it, you're in the middle of it, or you're just starting it. So I'd like to introduce 3 speakers. They were on the speaker page, but and I'm going to ask you to tell a little bit about yourself too when you get started. Stacy Taylor, Elizabeth McCormick, and Jenny Hobbs. So Stacy, will you introduce yourself first?
Sure. I don't know how close to put it. I'm a loud talker, so I may not even need this, but please let me know if I do. So my name is Stacy Taylor. I live in Baltimore, Maryland. I have 4 children, 2 of whom have genetically confirmed mitochondrial disease. And do you want to go ahead and have everybody introduce themselves?
Have them introduce themselves first, and then we'll go into your journey and the others.
Hi, everyone. I'm Elizabeth McCormick. I'm a genetic counselor at the Children's Hospital of Philadelphia.
Hi, good morning. I'm Jenny Hobbs, and I live in Winston-Salem, North Carolina. What else are we saying at the beginning? Just that?
That's plenty, whatever you want to share, because you're getting ready to launch into your journey. So I'm going to get started with Stacy. Tell us a little bit about your journey, and then I'll do some probing questions with the others as well.
Some probing questions. Now I'm concerned.
Don't be scared.
So I do have some notes. I have a horrible memory, particularly for dates. But so as I said, I have 2 children with genetically confirmed mitochondrial disease. They have what is called combined oxidative phosphorylation deficiency type 11, which is also referred to by the gene that's mutated RMND1. And Dr. Goldstein is going to correct me if I got anything wrong. So mitochondrial disease, as you all know, is a rare disease. On average, for rare diseases, I read on Dr. Google, it takes about 4 to 5 years for diagnosis, but it can take much longer. Some of you are probably in that longer diagnostic journey. So my son Marshall is 18. He was born in 2007. Sam followed shortly after in 2008. They are about 18 months apart. That wasn't planned. That was very irresponsible on my part. So Marshall was first referred to neurology at about 9 months old in 2008 because he was not hitting developmental milestones, which is also when I found out I was pregnant with Sam. He was originally diagnosed with benign congenital hypotonia. So that's just that floppy baby, low muscle tone, no real reason why, just, yep, he's floppy. And then for him, more and more diagnoses started piling up. Sam was born in 2008. And our first indication that there was something going on with Sam was that he failed the newborn hearing screening. Marshall had also failed, but then ultimately did pass, which we found out was actually an error because they are both, in fact, hard of hearing. So they were both referred to neurology for additional testing at around the same time. And they were both given sedated MRIs at around the same time. As a result of that, they were diagnosed with, and here's a mouthful, non-progressive leukodystrophy with bilateral temporal lobe cyst without megaloencephalopathy. And that was in 2009. I know, right? I sound like I know what I'm talking about. That was in 2009, and they were referred to the Myelin Disorders Clinic at Children's National in DC. So as I said, I live in Baltimore. We are in sort of the epicenter of these nationally and internationally recognized hospitals. I'm 15 minutes away from Johns Hopkins. I'm an hour away from Children's National in DC. I'm supposed to be an hour and a half away from CHOP in Philly, but it never takes an hour and a half. It always takes 2+ hours. So we're in it, like we're in the right area. If you are in a rare disease diagnostic process, we're an hour away from NIH and Bethesda. Like we're in a good part of the country. So we were referred to the Myelin Disorders Clinic at Children's National, and that was in 2009. It wasn't until 2014 that Marshall was referred for genetic testing for suspected Mito. So I often, when I describe our diagnostic journey, I refer to it as very linear. We were believed. We did not have to advocate in any way. The providers that we were seeing really led us step by step through the process. With each new diagnosis and with each new specialist, an additional piece of information was learned. And then with all of that information, the provider that we were seeing at Children's National, Dr. Vanderver, who is not a mitochondrial disease specialist, but she sort of put those puzzle pieces together and said, you know, I think I know what we're dealing with. I don't want to tell you what I think it is yet because I don't want to freak you out and I want to confirm it genetically. So she referred Marshall for the genetic testing. She thought she had identified what the gene was. She had our 2 older siblings come in to rule out whether that gene was mutated with them as well, because they were not symptomatic. She referred Sam for genetic testing. So it was all very coordinated, step by step. We were directed for the next steps. As I said, we didn't really have to advocate. We didn't have to fight. Everybody believed us. You know, it was clear that they had disabling conditions. But ultimately for Marshall, it took 7 years and 7 months for him to be diagnosed. Now, remember, the average is 4 to 5 years for a rare disease. And technically for what they have, RMND1, that would be considered ultra rare, because the last number that I heard was that about 30 people worldwide have been diagnosed with RMND1. I'm looking at Dr. Goldstein because nobody knows. She's got, right. So it's low though. It's low. It's not 0, but it's not 100. And even 100 would be low. So the definition for rare disease is under 200,000, I believe. So it's low. It's ultra rare. So for us, you know, for Marshall, 7 years, 7 months, that's higher than the average. For Sam, because he had his older brother leading the way, it was 6 years and 4 months, still above average. And as I said, Mid-Atlantic, world-renowned facilities, very linear process, no advocacy needed, no doubts, no suspicions of, you know, mom is just making things up. And it still took almost 8 years from birth until we got a diagnosis. And that's our story.
Thank you, Stacy. I'm going to move on to Jenny. Tell us your diagnostic journey.
Well, just to start at the current state, and that I would say we're still in the middle of it because we don't have a genetic diagnosis. So our son was born in 2002, and he had his first metabolic crisis at 15 months. And then our next daughter was born in 2004. So now they're 22 and 20. She started having issues around the same time, 15, 18 months was when we're like, she really isn't meeting milestones. So maybe we need to look into this a little bit further. But we managed her almost immediately, like we did her brother. And for the longest time, we thought that they had a glycogen storage disease because he had a liver biopsy at age 4 and came back positive for high glycogen, but none of the genetic, not genetics for that disorder or for any of the types. But that was sort of what we lived with until we found out both kids were in respiratory failure, and my son started having seizures, and that's when I was pregnant with our youngest. So she was born in 2009. We had, I guess, probably fortunately moved to Indianapolis like the year prior. So they were being viewed as sort of all new eyes just because of the nature of moving. And actually one of their other doctors before we moved referred us to the NIH, what was the Undiagnosed Diseases Program. And now, because it was only at NIH, and then later it's now expanded to the Undiagnosed Diseases Network because they have facilities all over. But we still came out of that experience, did not get genetic testing. But I remember sitting in the geneticist's office getting the results for Michael. So by the time the results were back, I think Maddie was like 3 or 4 months old and had been having issues since birth. And he comes in and he was like, well, I'm sorry, I missed it. He had a muscle biopsy in there. When I had a very, very, very young baby, I remember going, are they going to let me breastfeed her while he's in the hospital recovering from the muscle biopsy, which they would not. But anyway, all that to say, we found out that his muscle biopsy indicated mitochondrial disease. And at that time, back in late 2009, early 2010, that was the gold standard. There wasn't much out there genetics wise to pursue. And so we left saying this is the diagnosis. And I remember he said, most kids of this don't make it to 18. So fast forward to now, he's 22. I actually texted with him right before this session and he's like, can I call you? Because I asked him what state he was in. And so I'll have to find out later this afternoon, but he graduated from college. Connecticut? Okay, well, okay. Anyway, there's the update on where he is, but he graduated from college in May, and during COVID, when he actually forgot to re-register for a dorm when you were supposed to. So he ended up without housing for fall semester of his sophomore year. So he was like, well, if I'm doing all virtual classes, then I can kind of do that from anywhere. So he drove out west. And in fact, St. Louis was his very first stop for his very first national park, and was gone for about 7 weeks, I think, car camping and kind of exploring. So now that he's graduated, he was like, well, until I run out of money, I'm going to, try to hit even more national parks before I have to, become a real adult and get a job. So that's kind of his update, which is amazing considering we were told he would never, be anything like the state that he's in right now. Our next daughter, so we also have an older daughter that's 25 that's unaffected. Our 20-year-old is here. You might see her with the rainbow-colored wheel spokes. Oh, she is here. Here, not just present at the conference, but so for her, it's been more difficult, especially the last couple years. But at the same time, she's here. She's 20, and she's actually living in the dorm 2 hours away from us. Which don't get me started on nursing difficulties, but she really is doing amazingly well. And then our youngest is 15 now and also doing pretty well. So that's, in the meantime, we actually just did genetic testing on your sister, I think. So with having 3 affected kids, they don't always know which kid to test with what test. And so it's been a conglomeration of testing, and we're still waiting on our answer.
Thanks, Jenny. Elizabeth McCormick, I want to ask you about your experiences as a genetic counselor working primarily with mitochondrial disease patients. What do you see? What is it like? What's different about it?
Yeah. So, so I see folks in our clinic that have mitochondrial disorders or suspected mitochondrial disorders. And everyone's journey is definitely different. Some people come to us with their genetic testing report. Maybe it is confirmed to be the answer for them. Maybe one doctor told them one thing and another doctor told them something else, so they have no idea. And some patients come to us and the genetic testing hasn't found anything. So we really see the whole spectrum. And for us, it's really important for the people that don't have a diagnosis based on genetic testing. It doesn't mean you don't have a disorder because we haven't discovered all of the genes that are to be discovered yet. It just means we need to keep looking. And then for the families that come with that kind of in-between result, is this the answer? Is it not? A lot of times there is studies that we can do, additional testing, testing family members to kind of learn, more if that could be the potential cause or not. And then when families do come to us with that genetic diagnosis, it does kind of help us focus, what do other people with this condition have? What do we have to be on the lookout for? What clinical drug trials might you be eligible for? So we definitely can see the whole spectrum, but we found people definitely need support everywhere along that. And we've spent a lot of time kind of studying what is that journey like for you. Of course, finding the genetic diagnosis for everyone is the goal, but that might take some time. So we want to be able to support people kind of wherever they are along that journey as well. So a lot of patients come to us with challenges getting insurance coverage. It depends. I kind of joke what way the wind is blowing, if insurance is going to cover the testing that week or not. That can be a challenge, but there's other kind of opportunities that we can help them find, whether it's through research or the no-cost testing program to find a diagnosis. So we think there's always more that can be done. We never really turn anyone away. So hopefully that can encourage all of you that are still on the journey to keep looking and keep pressing forward to find that diagnosis.
I have a question for our audience. How many of you have had access to genetic testing? Probably half, I would say. For the panel, have any of you had roadblocks to getting genetic testing? Dr. Goldstein, do you want to talk a little bit? Hand on the mic.
So I'm a child neurologist by training, and before I moved to CHOP, that meant that I was in clinic without access to having my own genetic counselor, right? So I had to do what's referred to as panel testing, right? So I might be ordering Mito panel, right? So common nuclear genes, or, now we kind of dread those, right? Because you don't get full sequencing, you don't get exome, you don't get genome. And honestly, those were things that really were not available when I started my career. And then after moving to CHOP and being under genetics, then I had access to having people like Elizabeth and Jamie and Colleen and, and Emily, and having a genetic counselor with me. And so then when you have access to things like whole exome sequencing, whole genome sequencing, that part of that requires that you have genetic counseling, right? You need to know what you're getting yourselves into, right? There's a consent process. And so that's partly what the genetic counselor is helping you through, right? Like, what does this mean? What does this mean when you have exome sequencing, genome sequencing? What are the possibilities that we're going to have when we get those results back? But one of the issues that I face now is that there's some insurance companies that, as a neurologist, I'm not allowed to send that testing, right? The testing has to be sent by a board certified geneticist. And so even though I'm in Mito clinic and meeting people who need genetic testing. I'm not, as a physician, I'm not the one who's allowed to send that testing. So there are some times where I have that roadblock. And then I'm like, oh, is there another doctor here who can send this testing? And, I'm in clinic with a genetic counselor, and it's like, okay, somebody just traveled from California to see me, and now I can't send the testing. And we're just like pulling our hair out. So, and it's a little ridiculous.
Well, I'm sure there are other families in the audience that have had access problems, and that's something that UMDF certainly has been working on with our no-cost genetic testing program. I'm going to move on to our next topic. We're going to be talking about building and or changing your care team, and this group will include Ann, Stacy, and we'll get you at the end, Dr. Goldstein. So I'm going to start with you, Ann. Let's talk about what that's like. Your story about building your care team.
Well, first of all,
Oh, you need the mic.
genius. I'm Ann Korsen. I'm from New Jersey. This is my husband, Howard. And much like Stacy, if you have an older child, if they go to their first sleepover, surprises happen. So my daughter, Mara, has PDCD, and I'll just say she was diagnosed with mitochondrial myopathy at 3 months of age. We are lucky. We live in the Philadelphia metropolitan area. We had, thank you, short person. We had a second opinion at Hopkins, all the same. And with the help and where we are locally in Philly, we have a very good support group in the early days between our pediatrician, all of the various specialists that my daughter had to see. The neurologist, the orthopedist, the pulmonologist, the cardiologist. The difficulty that we've struggled with, and that's why we're here, is to help everybody understand if all of your specialists are generally in one vicinity in one location, that makes things easy. If they are spread out as you move around or they move around, it becomes a challenge. Our biggest challenge was not when she was little, as we transitioned from pediatric to adult, and finding the appropriate adult physicians that were willing to take on a special needs child, number one, a rare disease, number two, nonverbal, and anything else that would come with it. But again, we were lucky with the guidance of some of the CHOP personnel. We have a number of friends and physicians in our area that said, let's try this person. I'll make the contact. The most difficult thing that we had to do was find a GP. And that took a while because several of the ones that were recommended said, no. We ended up with our current GP, and he took the time to study and an hour-long conversation with Mara's neurologist at the time. Would you like to add something?
Yeah. I'm Ann's husband. The real quick, just on the genetic testing part before, Mara has PDCD, and we waited 21 years to get a diagnosis, and it wasn't, I beg your pardon? Of name of who?
PDCD.
Oh, pyruvate dehydrogenase complex deficiency. I'm sorry. And we waited 21 years to get a diagnosis. And it was because the testing was available, but it was prohibitively expensive. When it was first brought up, it was going to be $10,000. And her neurologist said, don't do it because it's not going to change. There were no treatments at the time. Mara will be 30 years old in August. There were no treatments at the time. They said it's not going to change the therapies or anything else that we're going to be doing. And the cost came down, but it was still, even if you get the testing done, it's not going to change much of anything. And finally, when she was 21, we got a full mitochondrial DNA screen that confirmed pyruvate dehydrogenase complex deficiency, PDHA1, and it ultimately didn't change her treatment regimen or the medications that she's taking. The only thing I'd add other than that to what Ann said is, I guess there was a question of, do we have a case manager or a care manager? We are doing it all on our own. And we found the most effective way to communicate with our doctors, and they're basically at two different locations. They're basically CHOP doctors, or they're within a network in New Jersey within the Virtua network. And they both use the same platform or have access to my CHOP and my Virtua or whatever it's called. So they can see all of the communications back and forth, but we're kind of the quarterbacks. We found that using the portal is the most effective way to communicate. And I want to add one other thing. Every year, and I know Dr. Goldstein has heard this, every year when we tell them the what's available to us in this area, they say, you don't know how lucky you are. As I said to you last year, and you too, Elizabeth, we know how lucky we are. These two are absolutely terrific. And I have not been paid to say that. So there you have it.
Thank you, Ian and Howard. I'm going to move on to, my brain just left me. Stacy, building a care team. Passing the big mics.
I probably could just yell at y'all. So yeah, building a care. Okay, let me think about what I want to talk about here. So as I said, like our diagnostic journey was very linear. It was like one referral after another referral. So that really was what our care team, building our care team was like too. We weren't really making conscious decisions about building a care team. We didn't know that's what we were doing at the beginning. I will say that we did change our primary care pediatrician very early in the process, because when Marshall was showing signs of not hitting his developmental milestones at like 3 and 6 month checkups, her response was that kind of, well, let's just wait and see. And then her response at his 6 month checkup was, and I had twins who were only 21 months when Marshall was born. I really didn't plan all this well, y'all. I had twins who were only 21 months when Marshall was born. So, you know, we had a busy household. And so her response when I expressed concern that he wasn't hitting developmental milestones at his 9 month check was, you're not giving him enough tummy time. Like it was my fault. Technically, it's my fault because he does have a rare genetic disorder that he did get from me and my husband. Technically, it's my fault, but it wasn't because of tummy time. So we changed pediatricians. I didn't really like that response. So then the new pediatrician at his 9 month check referred us to a neurologist that was within network. I mean, a lot of it is just all about like who's going to cover the appointment. Who does the referring doctor have a relationship with? Who are they in network with? So it was really that just kind of like, okay, so pediatrician refers us to neurology. Neurology gets a diagnosis and refers us to a specialist in their particular diagnosis, the white matter disease, myelin disorders clinic at DC. But then as we sort of started accumulating more and more diagnoses and seeing more and more medical professionals, we started becoming a little bit more savvy about what we were looking for. And we also started realizing that, you know, we got a lot of people on the rolls here. We need to have some way to coordinate with all of them. And as Howard mentioned, the electronic medical records are a really great way to do that. And I think in part, our journey was really also the journey of increased use of electronic medical records. When they were first going to the first neurologist that they saw, and even to the myelin disorders clinic at Children's, we weren't getting information through the EMR, the electronic medical records. It was still a printed out piece of paper that was mailed to us. It wasn't even printed and handed to us at the end of the appointment. They weren't taking notes at the appointment. It sounds like it was the dark ages. It really wasn't that long ago. But they weren't taking notes and handing us a printout at the end of the appointment. It wasn't in the electronic medical records. It was all, I had to write down my notes. I didn't even have a cell phone back then. So it was a lot of our building of the care team and sort of honing our care team has been as a result of the advances in technology. And then I think the other thing that it's been a result of is really just trying to find that ultimate expert, right? There are now a lot of experts across the country, a lot being relative in mitochondrial disease. There are not a lot of experts in RMND1. If there are 30 or so, or we don't really know the exact number, 49 people with, I love you. She's on it. There are 49 people diagnosed with RMND1, but they're not all in the United States. They are spread throughout the world. So however many there are in the United States, if there is an expert in RMND1, she's sitting at the end of the table here. And I learned that through attending conferences like this. I presented on a panel about my experience, my children's diagnosis, and I said they have combined oxidative phosphorylation deficiency type 11. And Dr. Goldstein came to me and said, I've seen your kids' MRIs. So that's sort of an aside, but I think that just illustrates the importance of getting involved, of coming to conferences like these. So after talking with her, I went home and I said to my husband, we're driving an hour to DC. Let's drive 90 minutes to CHOP. She knows this disease. She's the ultimate expert in RMND1. It had nothing to do with the quality of care that we were getting at Children's in DC. It had to do with finding that ultimate expert. And I'm going to pass off the microphone. I think the one last thing that I want to say is when you do make the decision to change providers, sometimes it is about finding the ultimate expert, as we did with Dr. Goldstein with the neurogenetics component of it. Sometimes it is about feeling that you're not really getting adequate care, that you're not being listened to, or that that person doesn't really have the needed expertise in mitochondrial disease. But it's not just that they don't have the needed expertise in mitochondrial disease. It's about that willingness to learn. And I think that's what sets a lot of the experts, the providers and the scientists who come to this conference every year. There's that willingness to learn. There's that willingness to say, I don't know the answer, but I'm going to look it up and I'm going to find it for you. And then there's that innate curiosity that they all have where they say, you know what? I don't know the answer. Not only am I going to look it up and find it for you, Stacy and Marshall and Sam, I'm going to look and find it out for everybody else who might have the same question or a similar question. So there's that willingness to learn that not everybody has, and there's that innate curiosity that not everybody has, that I think really sets those mito specialists apart, that we all are searching for, right? That ultimate expert and that willingness to learn.
Can I add one?
Thank you, Stacy. Dr. Goldstein, I wanted to ask of you, you have worked in places where you have it like now, where you have a team of experts that a family that attends there can have a care team that is partially built around them. What would you suggest for somebody coming to a team like yours? And also, what would you suggest for someone that maybe lives in a more rural area? What steps do you think they should take when building their care team?
Yeah, so not everybody, as you said, lives in an area where there is a lot of mito expertise. And so what we do know is that most people who have a mitochondrial problem, these disorders tend to be multisystemic, right? That's what we talk about. So it's really important that we identify what are the symptoms and that you have a specialist that can take care of those symptoms, right? So the symptom management is really important. And what I emphasize when we're in clinic is that the person that you're seeing, the specialist, does not need to be an expert in mitochondrial disease. That's why you're coming to us. But what they have to be an expert in is that symptom, right? So that let's say that you need to go see a cardiologist, and that cardiologist needs to be able to do an echo and an EKG, and we will write down look for an arrhythmia, look for cardiomyopathy, and that's the job of the cardiologist. And we'll say, this is the name of the gene, this is what we see in this disorder. And if we say you need to go back every year for the screening, the job of that cardiologist is not to say, oh, never mind, I didn't find anything, come back never. Okay, if that's the response that you get, then I go to my nurses and I say, never refer to that doctor again. Fine, we got to find somebody new in that area, right? But if I hear from my patients, we went to Dr. So-and-so in wherever it is, Nebraska, and they were amazing and very interested, and they wanted to read about this disease, and they said, please come back in 6 months. Then I say, write that name down, and that's who we're referring every single patient to who's from that area. And we have a whole database now of, okay, we have a lot of patients from Orlando. We have a whole network. Like, we know who to send our Florida patients to. If somebody's from New Jersey, we know who all those local doctors are. Harrisburg, Lancaster, like we have our whole regional area, Maryland, right? So we know who these regional people are. And again, we have people who come from all over the country. So we collect this network, and if people give us feedback, we know who the doctors are that we refer to. And we also kind of have that doctor blew our patient off and we're not referring back. We also have, for the children and for the adults, there's now a lot of people who are doing complex care, right? So one of our doctors, Matt Demsko, who was here, he does complex pediatrics. There are now complex transition doctors who kind of are bridging this gap between pediatrics and internal medicine, and they specialize in transition care. So the kids that are turning 18 and needing to transition onto internal medicine specialists, they're kind of doing this match service, and CHOP has this program, and a lot of academic medical centers are doing this, where they're saying, oh, you need now a renal person to take you from pediatrics to adult practice, and they'll ask your pediatric renal person, you need to transition your patient, who is the adult renal person you want your patient to go to, and they'll do this whole team approach to do a handoff, which is really, really great. And they try to do that again, kind of in a streamlined way, I'd say, and they try to do that with a few years in advance. So trying to put that into place around age 16 so that it's not happening all at once, and you have a few years to try to put that into place. The one other thing I want to mention as we kind of get ready for that 18th birthday is that I also try to make sure social work is involved, because something terrible happens at 18, right?
This is the next topic, Dr. Goldstein.
Oh, that's our next topic. Okay, well, so I should save it, right?
Well, yeah,
Okay.
and I want to include you in that conversation.
Yeah, sure.
See what you think from that perspective. So what I'm hearing is that there really are options in terms of what people are experiencing. Pardon?
Electronic medical.
Absolutely.
I just want people to think
Microphone.
about, I know for me, with everything being electronic and the portals, we often get our lab results before our doctor may actually even call us. I know not to Dr. Google. However, it is so tempting to Dr. Google, and I have no idea what I'm looking at. So often these blood works balance each other out, and I'm looking like at a lactic acid, and I'm not freaking out, and I'm calling Dr. Zokibli because I am extremely worried. And she's like, oh, no, don't worry about it. So I just want to put that caution there. Don't open it if it's going to make you more anxious. Wait for your doctor to talk with you about the labs, because it is so easy to just be like, oh, look, and yeah, don't Dr. Google it.
That is an amazing tip. And I think that applies to anyone, whether they have mitochondrial disease or not. Don't do it. So the next topic that we're going to move on to is transitioning to adulthood, and specifically that 18th year, and what needs to happen, and the roadblocks that people or problems that people encounter. And I'm going to turn to Ann and Howard to start with this, and then I'll move to Elizabeth and to Dr. Goldstein next.
I'll start. There you go. First of all, speaking of referrals, thank you for referring us to Dr. Fonseca. the ENT. He is absolutely terrific. So there's your feedback.
Do you know he scoped her
He was
and
able
she
to-
stayed still?
She stayed still. He was terrific. Okay. So transitioning to adulthood, the first thing I want to stress, and we'll get into it a little bit more in the financial section with Jenny. Once your child turns 18, if they are not competent to manage their own care and call an insurance company, why is this being rejected? Or call a doctor and get information, or get test results, or talk to a doctor's office. You need to make sure that at a minimum, you have a power of attorney that would be held either by a parent, or if that doesn't make sense, by someone that the individual trusts. Because you don't want to be in the situation that I was in, where I called an insurance company that denied coverage for something, and they wouldn't talk to me because Mara was 18 years of age. She's nonverbal, among other things. And they said, well, we need to talk to Mara. I said, Mara doesn't talk. You need to talk to me. We can't talk to you. So we ended up getting the paperwork squared away as quickly as possible, after I almost had a stroke. And we got that taken care of. In addition, and we touched on this briefly before, you know, one of the problems we're finding doctors. And the other frustration, and we've already talked about that, so I'm not going to belabor that. But we also, once she turned 18, every place seems to have different rules. Some of the pediatric providers would continue to see her and treat her, and some would not. She's still seen at the Mito clinic, and the gastroenterologist at CHOP continues to see her. But when he retires, we're going to have to find somebody else. That'll be another one down the road. The biggest frustration that we have right now is that Mara is 4'7" and weighs 72 or 73 pounds. So when you look at her, she presents as if she were, and she has microcephaly, so she has a small head. She presents as if she were an 11 or 12-year-old. But if we have to put her in the hospital, or go to an emergency room, or go to, obviously, an urgent care, it's adult physicians that are going to treat her. Some just don't have a good understanding of mitochondrial disease. And the other thing is, because she's that small, if she's hospitalized, sometimes they have difficulty in the adult section accessing the necessary equipment. Why are you smiling? For her care. For example, to get a urine specimen, the only way that you can get it is to catheterize her. They didn't have the right catheter, and we had to wait an interminable amount of time before they found a pediatric catheter. And now I'll pass it on to my wife.
I would like to just add a few things. Aside from the frustration and the concern because Mara is small in stature and presents more like a pediatric case and nonverbal, there is a tendency to put her, when she's admitted, in an adult or a geriatric ward, which is lovely. She's in a bed that doesn't fit her. And then you have to find all the other towels and cushions to take care of her. One of the things that we discovered when Mara was 18, right at that cusp, was she had to be admitted to the hospital. Luckily, we had people fight, and she ended up being airlifted to CHOP. But the one thing that I say, with all the electronics now, you should have, if there's instructions from your Mito clinic or the Mito doctor, that should be, we do it electronically. It's in Mara's wheelchair. We have electronic copies of powers of attorney, not powers of attorney, guardianship. We have all of that, both electronically and in her wheelchair. We also, it's on her med alert bracelet, et cetera. And the first thing out of my mouth is, here's her instructions. Don't touch her unless it's really bad. Call the Mito clinic. Get a hold of one of her physicians. That's the way I turn into a rabid dog. But that's the way it has to be. That's the way we do it. There have been times where we were left in a hallway and she aspirated, and the nurse handed me the suction. So try to stay calm. And keep in mind, if you have all of your guns in order, if you have whatever you have, whether you have a diagnosis or not, and all the necessary documentation that you can advocate for yourself or your child or your loved one, that will get you much further and keep things calm. And then
You're very right. I'm gonna, I think we have the microphone between the two of you, so you both be able to pipe in. Elizabeth McCormick, I'd like to hear from you when you have a patient that you're working with, what's the process? How do you get them started? How do you get them to social work? And same thing for you, Dr. Goldstein. What do you tell your patients? What should people know as they're thinking about this transition? And what do they need to know well in advance? And what kind of advice can you offer?
Yeah, so we love working with social workers. The problem is there's just not enough of them. So we do, unfortunately, not quite have one in our center right now. We're in between. But it is challenging because they do just bring so much to the care and the transition. However, we're also always not the only clinic that they're seeing. So we say, if you're having predominantly GI symptoms, maybe your GI team has a social worker. Or if you're having, neurology, maybe the neurology team. So I think it is important to find that person wherever it might be. Maybe it's someone through the insurance company. I think too, it's important to crowdsource among you all. A lot of times our patients ask us a question who they should see, how they get care. And we're like, well, we don't really know, but I think if you put it out there on the UMDF, Facebook groups or your social support, you all, probably everyone in here, if you brought everyone together, maybe we do have that adult endocrinologist and nephrologist and everything. So I think it's important to network with all of you and share your knowledge as well, because sometimes we do just get stuck and we don't know who to necessarily send you to.
Yeah, so just to echo what Elizabeth said, we used to have a full-time social worker devoted to our clinic, and we don't have one right now, but that doesn't mean we can't put in a consult to social work. It just may not, like somebody can't come into the clinic room that day, but we can have somebody phone later. So there are social workers at CHOP, but we just have to share with the other clinics. So we have access to them, but it doesn't happen immediately. And I will just say this process of going through getting medical power of attorney, guardianship, all that takes a very long time, and it is not easy. And so this has to start well before the 18th birthday, because what I've had happen to patients is that somebody will turn 18, and the day that your child turns 18, you will be locked out of their medical records. You will not have access to my chart or whatever you call it in your hospital, the portal, all of that. And so like if you right now have access to all of that, like, and if your child doesn't know their username or their password or all of that, like suddenly you won't be able to have it. You can't be their proxy anymore unless you get legal permission to do so. And that's the whole point of having medical power of attorney and all of that. And you want to be able to maintain that unless, again, your child is fully capable of having access. Like, is there a question in the back? Are we taking questions now, Margaret? Yes.
Like I said, anybody can ask a question if they
Mhm.
need about a specific topic. I can't see where the
In
person
the
is.
back behind the wall. You can't see.
Oh, it's because the bar's there.
There we go.
Oh, it's you, Whitney. You're talking microphone, so I'm coming.
Hi, my name is Wendy Mellon, and I have a 27-year-old daughter who's affected back here named Trisha. And we ran into this situation and we thought we had all the information because we'd been to these conferences and everything everybody is saying is true. We had filled out the paperwork that the hospital provided. Don't do that. Get an attorney, because we filled out the paperwork and it was written in their favor, for the power of attorney and living will and blah, blah, blah. Looked legit. Looks like the stuff online. Why would I not believe it? But when we went to use it to get her medical records, they said, oh, we can't honor this one. We were in a different state, so maybe in Nebraska, but there was something that we were in Missouri at the time, but it was filled out in Nebraska at a hospital. Anyway, check into, it's worth it. Make sure you have attorney look over whatever you've signed, because we actually ran into that situation, and the paperwork we had filled out initially worked everywhere we went. We'd give it, it worked. We get the medical records, then all of a sudden one day it didn't. But now we have paperwork that supposedly is more accurate.
Thank you, Wendy. See, things happen in these. This is why we have this session, for people that have learned. Oop. Oop.
You said well before 18, like a year, 2 years. What do you think?
Yeah, a year or two. Like around age 16 is when we start talking about the transition process, so that people have time to find doctors, specialists, because some doctors have like 6 months to a year waiting list. So, you want to start identifying who is it that I'm going to want to see, so you can get on waiting lists and that kind of thing. And then the whole legal process, like just finding a social worker who's going to help you, getting the paperwork together. Yeah, you want a year or two. Here. You have my phone.
I'm going to switch my hats for a second, because I'm not a Mito mom, but I'm actually a social worker as well. So if you do have children who are higher functioning, who may not need guardianship or power of attorney, there are like little back ways you can get access to their charts. You asked to fill out a release of information. So like for my son, I can't do guardianship over him. He wouldn't consent, and he doesn't need to consent. But with all of his doctors now, we have releases of information signed. It specifies that they can call me, that they can contact me. So sometimes that's like a back way. If you're working on guardianship or power of attorney, you can get that done pretty easily.
He's turning me back on. It'll just be a second. I didn't want you to hear the scratching. Is it back on? Okay. So thank you. This is very, very important information. We're going to move on to our next topic, which is understanding and accessing government programs. And this is going to be Jenny and Stacy. And just to let you know that you really truly do have the experts here. They did a talk about this for us a couple of years ago at conference. So I don't know which one did you plan on, who wants to start? Nope. Okay.
I could start. Is that the right slide?
Oh, no.
I was like, that doesn't look right.
Do we have slides?
Yeah, they're just.
I didn't
basic
do it.
topic Slides. Okay. Yeah, they're out of order.
I just didn't know if there's any kind of order.
Oh.
Okay, well, I guess I'll start. So I'm also a social worker, and did case management for 8.5 years. So this is a lot of what I did for a really long time. So kind of piggybacking off of the transition, I did want to also add that there's supported decision-making, which is where obviously for someone who still needs support, but you want to be able to give them choices about things when they're able to make decisions. So like, for example, we always talk about, who do you want to take care of you? Like with, if your child or young adult could indicate something like that, even as a yes or no question, like you do want to give them as much autonomy as you can. And I will say a lot of the courts, definitely in North Carolina, and it's a movement across the country, that they won't award guardianship if they feel that there is some lesser thing that would be appropriate for that child. So don't think that that means you don't get access to anything. You definitely can, but just wanted to also point out about giving everybody a choice about what they can choose. So Medicaid programs. So when you think of Medicaid, you were like me before I started doing this, you would think about, oh, well, that's for people who can't afford, or lower income, and can't afford their health care. And while, yes, that is true, there's also something called Medicaid waivers, which allows states to sort of waive certain criteria in order to become eligible for Medicaid. So for a lot of children's programs, they'll actually waive the parent income and only look at the child's income and I say child's income because I'll come back to that in a second. But these programs offer not only like full Medicaid services, hospital, doctor's office. Most states cover prescriptions, dental, eyewear, things like that. Also, most importantly, in-home care. But these waivers can also offer additional things that might benefit your family. So things like in-home care that's not nursing. So if you needed an aide to come in and help a few days a week, money for home modifications, vehicle modifications. You talk about lifting long-term as kids get older and heavier. You need help in that way, and it can get very, very expensive. So to get money to put towards that can be super helpful. I don't think it's on there, but the best way and easiest way to find out about kids waivers is to go to kidswaivers.org. And I know the person that runs that website, and it is great. And you can sort by state, and it'll tell you what services and the whole criteria that has been waived, and like what the new criteria is for your particular state. Do you want to?
No, and I was just going to say, and just so you know, if you can't get to that place, please feel free to call the UMDF. We help people find that page and the resources that are available in their community all the time. So please know you can do that.
Jenny knows so much about this stuff. She's such a great resource of information. I think what's really challenging with understanding and accessing government programs, which is sort of the topic heading here, is that they vary so greatly from state to state. So even something like Medicaid, which is a program-ish, it's really a state and federal partnership. So on the federal side of things, they, at least as of now, provide money for Medicaid, but then the state, each individual state really sort of makes the rules around what their eligibility requirements are for Medicaid and what all that means. And and then they sort of farm out the management of the people who qualify for Medicaid to managed care organizations in some cases. And again, it's so complicated because every state is going to be different. I think when Jenny and I presented on the Medicaid waiver programs in the past, I saw a lot of references that said, if you've seen one Medicaid program, you've seen one Medicaid program. So it's really important to try to familiarize yourself with what programs are available in your state. The Kids Waivers website that Jenny mentioned is a really great place to start, even if you're looking for an adult, because that will tell you what state agency to go to get the information. So in Maryland, the Maryland Department of Health coordinates a lot of that's where the Medicaid program lives. I don't know if that's true in every single state. That's also where the Developmental Disabilities Administration lives. And there are some things that an adult is eligible for that a child is not eligible for, and vice versa. So for example, Marshall just turned 18. We're in the process of applying for Social Security income for him. And again, it gets complicated very quickly, right? One of my girlfriends asked me recently, what's the difference between Social Security disability income and Social Security income? That's something that you have to figure out. If you are an affected adult and you're too disabled to work, you may be eligible for Social Security disability income, SSDI. If you are an affected adult and you have never worked, you may be eligible for SSI, Social Security income. So it gets really complicated really quickly, and it's important to kind of read and learn as much as you can. And then there are also services, for example, in my state, it's called the Developmental Disabilities Administration. It's run through the Maryland Department of Health. In your state, it's probably called something else. But once a person is out of school, then they may be eligible for certain services. And then even within that, there are two different types of services. So you may have self-directed services, or I can't remember what the other type is called, just traditional. Okay, so I think in Maryland, it's like either traditional or self-directed. And then there's different variables for that and what that means. So for example, in Maryland for the Developmental Disabilities Administration, you can and should apply at a very young age, but you're going to be placed on what's called the future needs list. But then once the child turns 18, you would be put on the current needs list and be assigned a case manager. But then they're really still not going to get direct services until they're actually out of school. So for my kids, they're getting a certificate of completion as opposed to a diploma, which means they won't finish school until they're 21. It's it gets so complicated so quickly. So I think the best advice really is to find somebody in your state who's knowledgeable. Each state has what's called a family-to-family health information center. It's the F2F. You can look up on Google, you can look up family-to-family health information center and find the one in your state. And they should be able to provide you with some information about what resources are available in your state and where those resources are coordinated through, whether it's your Department of Health, State Department of Education, or some other government agency. And I'm happy to answer any questions you may have to the extent that my knowledge would allow me to.
Do you have any information about Social Security disability for adults? What might they want to do?
Their Social Security disability income is based on how many work credits you have. You have to have worked in your life and now be too disabled to work. It does provide supplemental income if you are no longer able to work. That's SSDI. SSI, Social Security income, is more if you have never worked and are too disabled to work. And so like we're applying for Marshall for Social Security income. Another thing that someone did tell me, and I believe this is true, is that they deny everybody the first time. So and I think Jenny talked about this briefly during another conversation we had, appeal it. It's time consuming. It's a lot of work. But if you get denied for any of these programs, appeal it. Absolutely. Because we have been told anecdotally that they do deny everybody the first time. So I think if you're an adult or if you're a caregiver of an adult with mitochondrial disease, the first question is, has this person been healthy enough to work at any point in their lives? And then that sort of steers which direction you go in, whether it's SSDI or SSI. Apply for both. The worst they can do is say no, right? And then they have to tell you why they're saying no. So if they say no for SSDI, they have to say it's because you don't have enough work credits. Well, okay, so then do you have enough work credits? Do you think that they got it wrong? Appeal. Or if you have not ever worked, then okay, they probably got that right, but then you should still be eligible for SSI, the Social Security income. It gets so complicated.
I have a question for all of the panelists. Is there a recommendation of securing a Social Security disability attorney? I know many folks use those, and I've heard the same thing that you've heard and have experienced it with many of our patient families, that the first go round is a denial, but that I can't think of anyone that I know that was never, ever approved.
Yeah. I
So
can
you
talk
gotta
about that
keep
if you want.
trying. Is that what your experience is, Dr. Goldstein, with the patients that you work with?
I think one thing that I will say also before I pass it on is most attorneys will do a free consultation. So if you just have some general questions and you've been referred to an attorney by a family friend or a provider or whomever, most of them will do a free consultation and might be able to just sort of help you get started with a to-do list.
I was gonna also, so you're looking for two different types of attorneys, because I think we were supposed to cover this too. So, most Social Security disability attorneys don't just give you the free consultation, but they don't charge you up front. So they get a percentage up to the Medicare allowance, if you win. So you might have a hard time finding one that will take your case if it's going to be complicated. But know that they're putting skin in the game too, in terms of, doing all the work to try to get you approved, because they only get paid if you get approved. I also wanted to talk about special needs planning attorneys. So that is probably going to be someone different. I found out from our own attorney that he said your first place you would want to look for is to see if an attorney is a member of the Special Need Alliance, and that if you can't find one near you that is in that, to look to the National Academy of Elder Law Attorneys. So they can help you with the special needs trusts, which is how you help ensure that any inheritance that your child might receive from you or other family members or friends, that money is protected from Medicaid clawback. So you want to have that in a safe place, as well as if your child is able, or a young adult at this point is able to work, then you want to have an ABLE account so they can save money without that being visible to Medicaid or any other services that they might be currently receiving. Also, back to that kids waiver website, I was just going to add too that most states have more than one waiver. And for example, in North Carolina, we have 4 different Medicaid waivers, 2 that cover kids. One of those being they only cover kids, and then 2 that only cover adults. So you might be on the waiting list for one and receiving services with another. So you would want to apply for not just one that you might be eligible for, but potentially all of them. Because with our pediatric only waiver, that means that when they're no longer pediatrics, which in Medicaid's eyes is 21, then they have to get services a different way. So then they would want to transition to one of the adult waivers. So anyway, wanted to throw that in. And also the age for adult is very different because we talked about the age for adults in SSI's eyes is 18, but in Medicaid's eyes, it's 21 when you look at all of their policies and programs. So.
Jenny, you may or may not know this, but with the Special Needs Trust, if money were to come accidentally, like seriously, to them, can you put it in the trust? Or once it's been received by your person, that could kick you out of
So
services?
you can put money that's already been received, or if it accidentally gets, you can put it in a special needs trust, but it's a different type of trust. And so that money is potentially eligible to be taken,
Okay.
but.
So it's so important for it to
Mhm.
go directly.
So let your parents and grandparents know to not
Okay.
name your child as a beneficiary.
I just want to say I sat in this session with Jenny last year and it changed my life. I cry all the time. But
It made me cry.
it's so much stuff, one step at a time. Just take it one step at a time.
And focus.
Oh, I know it's a difficult journey to take care of all of this craziness. I'm gonna run over here. And we're gonna be talking about different kinds of financial information in a minute.
I just wanted to share real quick our struggle. It's not really a question, sorry. We're on the medically dependent children's program waiver, and my son's been on it for 5 years. We're also got on the class list. We're from Texas. That wait list is like 16 years. They denied my kid the services this year, so it gives us respite care, mileage reimbursement. It's done all this stuff for our family. We have our primary insurance. We have this. We were drowning in medical bills till this came along. So I got all the letters of medical necessity from all of their specialists. They still denied it because a new person came in charge. And then I applied to Disability Rights of Texas to represent us because we couldn't afford an attorney, and they denied us. And then I found in an email that I could appeal that. So then I appealed that. And so then they represented us. So I've been doing this for, I think, like, 6 months? And the attorney got us differently worded letters that the doctors then signed. And it was a 240-page packet he submitted. And before our fair hearing, they overturned it. So I had to do all that just to keep him on this program. And now they've denied his brother. So I'm about to do it all over again. But I mean, what they do is deny people and weed out the ones who won't who give up, who get tired, you know? So it is very important to, I mean, it consumes my whole life and I have a full-time job. So, but if you stay with it, you'll get services.
So I believe it was in Pittsburgh at the UMDF conference. There was a couple who gave a talk about getting Social Security and navigating that. And something they suggested was the Social Security book for dummies. Remember those ones? And I just, like, we got Social Security within a month. So, and not being denied. So I just wanted to give thanks to them and also tell you that it can happen that you don't have to get denied. But by sure, just keep plugging along, you'll get it.
Along the lines of the denial, everything that they said is true. We just went through an experience where we didn't even know what some benefits that were available to us, such as home improvement, things like a railing, you know, safe sidewalks that are wide enough and stairs to be able to get her down in a wheelchair or out of the house if necessary to be able to transport. And once we found they were available, of course, we applied. And you hear the old story that that gets rubber stamp denial. You know, you always hear that, but we actually found out that to be really true. The state really does that. We actually appealed it. We had an appeals meeting a few months ago and met with a gal who officially signed the letter of denial. And in the appeal, we had explained that, you know, she's on several forms of life support, ventilator, oxygen, TPN dependent, blah, 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 all the different things and why she needed some of these. And the gal who signed it didn't even, she said, "Oh, I didn't read it. I didn't know that." But she signed the letter and she denied it without ever reading about my child or my daughter, a young adult. So we appealed it at the time. She said, "Okay, yeah, we'll approve it," but we had to wait for the letter. And we got the letter. They approved it. But in the time that it took, the delay, there was a change in pricing well under the budget, well within what was allotted to her for, quote, say the year. Apparently, they can give up to $10,000 in the state that we live in for home improvements if there's something needed, you know, if it's ramps or bars in the bathroom or whatever. You can actually combine, and it's different for every state, but you can combine 2 years. So if that's per year, your project can actually, they can double that. Now you can't access the money again for a while, but so they approved it. But then we just got word the other day that it was denied because there was a few cents, as in pennies or dollars difference in what had been initially approved. So we had to go back and appeal again. And now we just got word it's been approved. But that's been a several-year process. But don't give up. Like she said before, you applied and denied and applied and denied. It's very common for them to deny, and that's weeding out all the riffraff. So be strong, keep at it.
Thanks, Wendy. I'm coming around. We're going to talk about financial planning next. So I'm going to switch up the slide and move on. And for financial planning, we have both Jenny and Ann. Jenny's going to give a little more in-depth talk about special needs trust, which we've touched on. Howard, would you like to get started talking a little bit about, or excuse me, Ann, would you like to get started talking a little bit about insurance?
Ann's going to have a deeper voice because
Oh, Howard wants to do it today. Sounds good.
Ann's husband is going to talk.
Right.
She ordered him to do
We
it.
flex here with
obey.
that.
Yes, ma'am. I could spend hours talking about the evils of insurance companies. I could also use a lot of words that are not appropriate. I have a unique, is this the financial planning portion, or do you want me to talk about insurance?
The insurance is part of the financial
Okay.
planning portion.
So insurance companies want to wear you out. If something is that pay close attention with your insurance company to what medications and procedures they want a prior authorization for. Because you're going to have to get a prior authorization. Your doctors can help you a lot with that. What I'm finding is that insurance companies, particularly now when it comes to genetic testing, the big five are adding a prior authorization to anything other, and Dr. Goldstein or Elizabeth, please stop me if I'm wrong. They're adding a prior authorization requirement to anything other than a single panel genetic test. And the reason I mention it is because if a medication that you want requires a prior authorization, you don't get it, it's not going to get approved. If you're denied, and the denial rates are pretty high. The last numbers that I saw, and the worst is United Healthcare, and they deny, this came from the Kaiser Family Foundation, something like, initially they'll deny close to 40% of claims. Appeal. Get your physicians involved. If you have a care manager, get your care manager involved. And when you're appealing, technique that seems to work for me is when you do whatever the appeal paperwork that you're supposed to do, even if you're not actually sending it to them, copy your congressman, copy your senators, copy someone high up in whatever, in New Jersey, it's the Division of Developmental Disabilities, but appeal. Because in a lot of cases, when you appeal, they will ultimately agree to cover whatever it is, particularly if they think you're going to hire authorities. I'll just give you one case. If any of you were here and heard my brief talk about the Medical Nutrition Equity Act, New Jersey is private insurers in New Jersey are required to cover it. That does not stop insurance companies from trying to deny coverage. 6 times, and it's the same insurance company, 6 times, AmeriHealth, Blue Cross Blue Shield in New Jersey, basically. 6 times they've tried to deny coverage. And every time I got a copy of the state law, which goes back to 1998, and I sent it to them. Usually that works. Well, okay, we're going to cover it. But finally, at the 6th time, I lost patience. And what I did was I sent a letter to the one other person that you should copy on your letters is the Attorney General in your state. Because believe it or not, they may actually be interested in this kind of stuff. I sent our Attorney General in New Jersey a letter telling him that AmeriHealth is in willful neglect of the law. This is the 6th time that it's happened. I send them the law. Can you take any criminal or civil action against them? That was at 4:00 in the afternoon. The next morning at 8:30 in the morning, I got a call from somebody in management at AmeriHealth. We made a mistake. We're going to continue to cover the medication. This is not easy. It's not easy to do. I know it's not easy to do because I get so angry. It's probably cost me 5 years off my lifespan dealing with it. And I have the unique experience of having advocated for people with special needs. Plus, in my working career, I was a contracts manager and I contracted for healthcare with insurance companies for healthcare for our employees and their families and retirees and their families. The last thing I'll say is, for those of you that are working and have employer-based healthcare, take that, once you've gone through open enrollment, take that lovely brochure with the smiling family on it, glossy brochure, and throw it in the trash. Ask for, and you are required to be given this by law, ask for a copy of the actual contract that your employer has with the insurance company. And if you can, get it in a PDF format so that you can search it. So for example, if you need a bath chair for your child, or a specific type of wheelchair, or something else, a piece of durable medical equipment, or a particular medication, or a particular treatment, or a particular CAT scan, you can just search that and you can find out that, what the document says they're going to cover, and what the document says they're going to cover. And when you read the contracts, you realize that they're not written with the patient's health in mind. They're written with the profit numbers of the insurance company in mind. So I could go on for hours about this, but that's the best advice I've got right now. You go to your HR department and you ask say to your HR department, I want a copy of the contract. And they are required by law to give it to you. They may give you a 150-page book which makes great bedtime reading. It'll put you out in a minute. They may give you the big book, but in most cases now you can get it as a PDF so that you can search it when you're looking for specific items that you want to get for yourself or your child.
Thanks, Howard. Would agree with everything that he said. A few things that I wanted to add to that. If you do have private health insurance through an employer specifically, there is a program in most states called the Health Insurance Premium Payment Program. And what it is essentially your Medicaid will do a review of that plan. And this is if the individual has Medicaid as well. They will to see if it's actually cheaper for Medicaid to pay your health insurance coverage, your premium every month, so that you keep your child or young adult on the private health insurance. And that way Medicaid is off the hook once you've met your out-of-pocket max, then your private insurance is paying at 100%. So the Medicaid doesn't have to pick up their portion. So so I guess that's 2 points. Is one, you can have private insurance and Medicaid, and then two, look at your state and look up that HIP program, HI2Ps, and that may be an option. In addition, when you're appealing something for children who have Medicaid, which remember that is up to 21, I talked about it yesterday, but there's something called EPSDT. And it's a really long name, so nobody calls it by the name. They call it by the acronym. But what it stands for is early period. This is what Medicaid is supposed to require for kids to cover anything that's early, preventative, screening, diagnostics, and treatment. I'm like, I forgot the S. So that means everything from genetic testing, if that's proven, if your doctor is saying it's medically necessary, Medicaid's going to have to cover it. New treatments come out, Medicaid's supposed to cover it. So not saying that it's going to be easy, but use that language. And they really don't like you to use the word ameliorate because that's what's written in their policy. So ask your doctor to make sure they include that in their letter supporting it, but that's a really important word and a really important thing to just make sure that that Medicaid's covering what it should.
Thank you, Jen. Yep.
Quick things.
Sorry, y'all are going to get sick of hearing from me. So one thing we talked about financial planning a little bit and special needs trust. And I know for me personally, I haven't done this. So this is one of those do as I say, not as I do things. You don't have to have money in order to need financial planning. I'm poor. You don't, but you still need financial planning. And if you have life insurance, whether that's through an employer or personal life insurance, that can be used to fund a special needs trust, which can then be used to take care of the care recipient after you're gone. So don't think like, well, I don't have any money. What do I need financial planning for? You do. The other thing that I wanted to mention is ABLE accounts. I believe most states now have ABLE accounts. That is a savings account that is designed specifically for people with disabilities. So it doesn't count as income in like Social Security income calculations. So if somebody in your family wants to give like a birthday gift to your child or an adult with disabilities, they can put it into the ABLE account. You can be on there as, I can't remember what it's called, but like a fiduciary person, and you can get a debit card for that person. And that money can be used for disability related expenses, but also for other expenses. So it's ABLE, check out ABLE account. And the other thing that I wanted to really briefly reiterate, and Howard mentioned this, is think about the resources that are available to you within your state delegate, your state senator, your attorney general's office. They have designated points of contact within a lot of these offices. So if you're applying for Medicaid and struggling, if you're applying for a waiver program and struggling, if you're applying for food stamps or any other kind of financial assistance or economic assistance program, unemployment, literally anything, and you're having trouble, contact your state delegate, your state senator, your attorney general's office, and they may be able to assist you because they have designated points of contact within these offices. That's a shortcut. So, and you voted for them. They want you to vote for them again. Maybe you didn't vote for them, but they want you to vote for them. Their job is to help you. That is what they get paid to do. Make them earn it.
One more I would add to the list of who to contact is your state Department of Insurance. So they also are in charge of managing all the insurances in your state. Even if the insurance is from Pennsylvania and you live in North Carolina, if they're providing care, paying for things in your own state, then the insurance commission should be involved as well.
Thank you, Jenny. And I just want to reiterate to everyone that, and in case I don't get to this at the end, tomorrow we're going to have coffee and conversations, and all of these folks are going to be there for you if you have any questions that we don't get to today. And I think my slides are out of order, so let me fix it. And I want to, there she is. And I want to talk, the next topic is medical interventions. And I want to talk about why I picked this and why I specifically asked Dr. Goldstein to be a part of this. We had a conversation, it was many years ago, I think, Dr. J, that we were talking about how heartbreaking it was when people come to you and say, there's nothing I can do, I'm just going to give up. And that's not the truth. And so I would like you to talk about what people can do, you know, short of a FDA approved medication, what kinds of things are available? And where should people be kind of placing their focus?
So I started writing my list knowing that this was coming. And I think you asked for like the top 10. So, but I don't even know if I have 10, like I probably have more than 10. So I wrote out some things, and I don't know if all of these are going to count as medical, right? Because some of them are drugs. And actually there's a session that's going on right now, and one of my colleagues just texted me, Dr. Sharma is sitting in that room. And there was a talk from Pretzel Therapeutics talking about their compound PX578, which will at some point have a drug name. But there's a drug for Pol-G, right? And so it looks like it's going to work, and we have to do a clinical trial, obviously. And but there are things happening, and there are things happening in that other room, and hopefully they'll come to clinical trials. And I have a list of the drugs, but I'll save that for number 5. So number 1 on my list is nutrition. And I talk about this with our patients all the time. And our patients say, like, does that mean I can meet with the nutritionist? And Elizabeth and I just had this conversation like 2 weeks ago, like, should all of our patients meet with the dietitian? And, we debate this because, I think everyone could benefit from meeting with the dietitian because, do people know what a healthy diet is? And our patients struggle with this because even if you know what to eat, it doesn't mean that you can always eat the way that you should eat, because most of our patients have GI issues and they can't always eat the right amount of calories, or they can't always eat certain foods, and all of those things. But when you boil it down to, what are our mitochondria trying to do? They're taking the food that you eat and the oxygen that we breathe and converting it into energy. So you need to be able to breathe, and most most people with mitochondrial disease don't have a lot of lung issues, right? So getting the oxygen in is not necessarily the problem, but making sure you don't have obstructive sleep apnea and all of those things obviously are important. But the nutrition piece is huge, right? You're using the food that you eat to convert it into energy. So this is a really big thing. We spend a lot of time talking about whether or not people need a feeding tube and are you getting enough calories and things like that. And that's, again, a huge conversation. So the nutrition piece is enormous. So that's number one on my list. Therapies, getting all of the therapies, physical therapy, getting enough exercise, the value of exercise, not getting too much exercise, not overdoing it, all the rest days. I was with the teens this morning. We spent a lot of time talking about swimming and aquatherapy and resting and then muscle cramps and all of that. So that was an interesting conversation, but just making sure you're getting all of that, whatever therapies that you need, including physical, occupational, speech, for the little kids developmental, getting all of that support. But I also spend a lot of time sending people to physical medicine and rehab, and we now have physical medicine and rehab in our clinic. And a lot of people say, well, what did they do? What kind of medical specialty is that? So physical medicine and rehab specialists are the doctors that make sure that you're getting all the therapy that you can get, but also what about equipment? Do you have all the equipment that you need? What if you need more equipment? Those are the doctors that know how to write the letters to the insurance companies to buy the equipment that you need, or making sure that, oh, you just got this and there's only so much that you can get in 1 year. So let's make sure that we ask for this year so that you can get, that bath seat next year. You need the safety bed, like making sure you get what you need at the right time. Tone management is also huge for a lot of my patients. So that physiatrist is also extremely important, and I really utilize them. They also know when to bring in kind of like more specialists. And again, I'm thinking about certain patients. Not everybody needs everything, right? But there are times where, especially my patients with Lee syndrome, they may need the physiatrist, this physical medicine rehab specialist, but then we need to take it up a notch and go to like either what's called CP clinic in some places, but also tone management, where it may involve a rehab specialist plus ortho plus, in some centers, more people. And again, those are for people that might have a movement disorder or have really high muscle tone, and we need to involve certain specialists to decide, is this problem going to be fixed with Botox, or do we need casting, right? So like very specialized people that know how to deal with certain high tone issues. All right, the next thing on my list, I have personalized Mito cocktail. And so there have been many conversations among the doctors at this meeting about who's using what cocktail. And some doctors I've heard say they're not using anything anymore because they're not convinced anything works. And do we need to talk about supplements again? Do we need to write a paper about supplements? And I'm like, I don't understand. Like, we wrote this really great paper a couple years ago with all of the preclinical science justifying why. I'm like, why isn't anybody using our paper? And then we have also all of these really amazing blood tests now that Dr. Ganetsky spent years in the lab, making sure that we know, like, well, how much niacin does somebody need, especially for the complex 1 disorders? How much NAC does somebody need when you have a glutathione deficit? What about all these other antioxidants? How much alpha lipoic acid do you need? How much vitamin E do you need? And so we're really getting good at personalizing the cocktail. She's now rolling out the coenzyme Q10 assay in our lab. So we're really starting to personalize, like, what do you need if you have SIRF1? What do you need if you have, a complex 1 disorder versus a complex 4 disorder versus a complex 5 disorder, like really going deep. So not everybody's on the same cocktail in our center. So I really like that that's our approach now. And I haven't even talked about, like, well, what happens if we do, some of our other research-based testing, like if you have a creatine test study and what are we finding on the muscle testing? And we're now doing brain glutathione measurements on a research basis. So we're really trying to personalize the cocktail. All right, going a little further, I have a whole list of like treatments for certain disorders. So if you have Barth syndrome, there's a drug for that called elamiprotide. And like, God willing, the FDA is going to approve this drug, and we don't know when, but there's such a hard push for this right now. I think I personally did about 4 interviews over the last 2 weeks for different news outlets trying to push this through. Hillary Vernon's here. She's done the same thing. The Barth Syndrome Foundation is going to do another huge push next week. Several of us are interviewing and doing more for that. So I think, again, I have no control over this, but hopefully the FDA is going to, they're going to let Stealth do another new drug application next quarter, and Stealth is working very hard to push that through. The primary mitomyopathy trial ended, and the data, I think Renee McCarthy is coming to this meeting. I don't know when. That might be happening today. Yeah. So I don't even know what the data is. I think she's going to be announcing it. We'll see what's happening with those results. Friedreich's ataxia is another disease under the Mito umbrella that has an FDA approved drug that we don't talk about a lot at this meeting, but omaveloxolone is approved for Friedreich's ataxia. They're opening the trial now for kids because it was approved for 16 and up. And so they're starting the clinical trials for children. We did that trial for mitomyopathy, and I maintain that that drug probably works for mitoataxia, but we used the wrong outcome measures when we did the trial. And I am still trying to get that company interested in using, doing whether we need another trial or we convince them to use it off label for mitoataxia. We still are having that conversation. The nucleoside therapy is probably going to be FDA approved for TK2. And then UCB is going to start answering questions about whether we can use that for other mitodepletion syndromes. So again, more to be heard about that soon. For POLG, I said Pretzel, it was just talking about their drug for POLG, and those clinical trials will hopefully start either later this year or hopefully by 2026. There was a presentation yesterday about using sildenafil for many different mitochondrial disorders, and this is happening in Europe now. Some people are using it with compassionate use, and some people are doing this on randomized controlled trial basis in Germany. For those of you who aren't familiar with the generic, you will be familiar with the brand name that goes by Viagra. So that is a vasodilator, but it also works at the mitochondrial level by holding on to calcium. This is a very good drug for Lee syndrome. This is a good drug for mitochondrial disease. You are going to see people using this. Is being used at Mount Sinai right now, and it was presented yesterday with really good results. And so all of us in the room are like, what do we do with this information? I'm going to tell you right now, we struggle with this. Are we going to do a randomized control trial? Or are we just going to start writing for it as a prescription off label? I mean, Elizabeth and I are now going to sit and be like, what do we do? They're using it in Mount Sinai right now. What are we going to do? So Dr. Demsko and I turned to each other and said, what are we going to go home and like start using it in our ICU tomorrow? Like, seriously, like this challenges us as clinicians, because if we have a drug that works, that people in Europe are saying, yeah, I'm using it in Italy. And Dr. Yair Annixter's here from Sheba Medical Center in Israel. He's like, yeah, I've been using this for a year in my MELAS patients. I'm like, so this is the value of us coming to the meeting. So we learn what other clinicians are doing. And this is not an ethical issue, but it's like, well, when you hear about drugs and we can use them off label, like, do we have to prove it in a randomized control way? Like, these drugs are available. Anyway, I'm kind of digressing a little bit, but the point is, like, these drugs are available. And if somebody has said they work for Mito, like, we don't have to put people through a trial. Like, if it works, it works. And, we can kind of roll with it. We just have to figure out for which diseases and, like, go ask the other clinicians who have been using them, who do we use it for and when? Like acutely in the hospital during a mito decompensation or just, mycophenolate, this is going to raise Jaci's eyebrows. Mycophenolate has been used in Italy for several years now for certain mitochondrial diseases with very good results. They haven't published it yet in a journal, but they're about to. And then we have to figure out, okay, are we going to start rolling that out? Same scenario, like, what are we going to do with this one, right? Are we going to do a trial? Are we going to just start everybody on it? So there have been 2 papers published in 2024. And I think Shamima Rahman was here last year, as was Anu Sulmanian. And they both stood up and said, we've now done all these studies showing the role of the inflammatory markers in mitochondrial disease. This has been known for years that there are inflammatory markers that we can show in blood work and in spinal fluid. So we know that there's inflammation in mitochondrial disease. If you walk into any rheumatology clinic, you will see them handing out these inflammation drugs to everybody, I mean, there are really good anti-inflammatory medications now, but these biologics. And at our hospital, there are some really nice new ones called JAK inhibitors. And we have access to some of these newer inflammatory panels on a research basis, and hopefully some of them will become clinical tests. And some of these drugs, these newer drugs, one of them is called baricitinib, they're using for a disease called Aicardi syndrome. And there's a very rare mitochondrial disease called PNPT1. And I think there's a poster here where they used one of the same JAK inhibitor for PNPT1 with really good results. This drug is probably good for more than one mitochondrial disease. And again, these 2 papers were published. The doctor showed these same inflammatory markers are raised in mito, just like they are in Aicardi-Goutier syndrome. The drug's available for that disease. Somebody said, okay, let me try it for PNPT1. But again, it's just almost like a slow rollout. So I get really frustrated with this delay. I just named 3 drugs that a couple people in the world are like, okay, let me try sildenafil, let me try mycophenolate, let me try a JAK inhibitor, 1 center, 2 centers. And everyone else is like, oh, should I? Okay. SURF1, there's somebody here from a drug company walking around who has a drug for SURF1, and we're waiting and waiting and waiting and waiting and waiting and waiting and waiting. And we're supposed to have that drug available soon. And hopefully it's going to be available soon for us to start a SURF1 trial. Or just open access. But we showed in an animal model that cysteamine is really helpful for SURF1, that and or NAC, and maybe a combination. And I've been waiting to run into him at the coffee break and say, where's the drug? Last year or even the year before that, I think we've been having the conversation. Yeah, it's time to so the good news is that there are, again, 4 or 5 drugs on my paper. Okay, if you have MTARS2 variants, so those are LARS2, DARS2, NARS2, WARS2, VARS2, they're amino acid supplementation. There are protocols in place now in Europe, and we've been working on one at CHOP for a really long time. But amino acid supplementation is, kind of was in favor, out of favor, where it's back in. And this is thought to be a very safe and probably helpful therapy to use. And we do amino acid therapy for MELAS, right? We put people on arginine, citrulline, taurine. And so if anyone here is familiar with those disorders, so that's using the cognate amino acid for that particular problem. So you have FARS2 using phenylalanine, DARS2 aspartate. So that treatment trials are in place and happening. PDH, we use the ketogenic diet and DCA is hopefully getting approved by the FDA. Like these are things that are like happening. They're happening now. NARP, there's a treatment for certain forms of NARP with acetazolamide for episodic ataxia, and that's something that a lot of our patients are on. So those are all treatments that are happening. There's one other thing I want to mention, and that's there's certain conditions where avoidance of certain substances can be really helpful. And so there's a big presence of LHAN patients that are here. And so we've learned a long time ago, if you have LHAN, avoiding smoke, not just tobacco, but any kind of environmental smoke can be very, very helpful to spare the optic nerve. So tobacco and any environmental smoke and alcohol. And then there's a newer disorder that has really kind of made a big splashdown, PPA2, and avoiding alcohol and vinegar, acetic acid. Like these are very, very important. And it's really good to know that from the get-go because that can be very life-saving. And so those are also important things. And I think it's going to be really interesting to see, like Dr. Hillary Vernon, who's here from Hopkins, she's now doing a lot of work in her lab to figure out what's actually happening, like what's happening. And she's going to try to help tease that out and figure out from the cardiac standpoint, what's alcohol doing? Is that going to give us insights into, there are certain forms of 3243 and MELAS where alcohol's led to certain cardiac arrhythmias. So she's going to help tease all of that out and figure out the connections between PPA2 and alcohol and MELAS and alcohol. And like, is there a common thread there? So that's everything that I have on my list. There's a lot.
That's a wow, though.
Really, again, these medicines and like people that are doing these, we call them N of 1 trials, right? It starts somewhere, but people have gotten like, we're not going to wait for massive clinical trials. And like, people are like, if something works, just going for it. And, but we want to do it still in a coordinated way. And I'm just going to say one other thing about this. The sildenafil trial, Marcus Schulke started doing in Germany, and the German government found out about it and shut him down and said, you have to apply to the EMA if you're going to do this. And Caterina Garoni in Italy, she's like, I don't have to do that. My government said, it's fine. She's doing an open compassionate use trial. And Marcus Schulke said, that's fine, but please do the same outcome measures that I would have done so we can at least combine data. And he asked the same thing of anybody in America. Like, if you're going to do it, that's great. Do open label, but collect the same outcome measures so we can at least compare. And let's at least like learn so that if I want to do it, we'll start it, but we'll figure out like, what's his protocol? What's the dosing? Use everything similar so that it's not a randomized controlled trial with placebos and all of that, but we're all doing the same thing so that we're still getting the benefit of learning. Does it work? Are we helping? So that it's not like random and we don't learn anything from the experience. And I think that's what's important, right? That it's all done in a similar way so that we're still gaining the benefit and the knowledge with, does it work? Because if we're going to do it, we need to at least do the same protocol and understand and learn, right? Because we don't want to find out like, oh, if we're not doing it the same way, then, there's not a way to gain knowledge from doing the same thing. So there's, again, a lot happening, a lot of potential drugs that are in front of the FDA and hopefully will get passed, and a lot of drugs that are really here and able to be utilized.
That's amazing. I just want to tell you that I've been coming to these conferences for like 13 years, and there's never been a list so rapidly
Accumulated.
put in front of us that shows that so much is happening. And I hope that gives you a lot of hope. We're going to move into our final stage of our time together. And unfortunately, I think we're going to run short of an activity I wanted to do, but that's okay because the next part's really important. There will be a handout passed out to you. I hope that I have enough. Could you bring me one, Bethany, so I can show everyone? So I want to tell you a little bit about what you're receiving. It is a page that looks like this. And there's a QR code. At your leisure, please hold your phone up to the QR code, because what we've done is I've reached out to all of our UMDF support ambassadors and asked them for a helpful tip. And they're all there for you to look at on your own time. On the back, we have a link to one of our UMDF resource guides. So please take advantage of that. The next thing we're going to talk about is, gotta get my slide right, and it's funky here. Hang on. Is emotional adaptation. This is the not detailed part of life with Mito that is equally important. The entire panel, I want you to jump in, but I think I will start with Jaci. So Jaci, do you want to lead us off and talk a little bit about this very important topic?
So, hi, my name is Jaci Leit. My son has KSS. As I said before, I'm also a social worker, so the mental health piece is something I really relate to. I like to use analogies a lot, and I find with the mental health piece, we are so focused on the medical parts of it, and mental health kind of gets let go. Then it's also, who's the mental health piece for? And I often, caregivers will be like, well, no, it's not me. The focus is often different. So I kind of think of it like a roller coaster. I don't like roller coasters. I never asked to be on a roller coaster. I'm on a roller coaster, but my son is in the front car. His perspective is different than mine. You know, if you're on a roller coaster, that first car gets you want to be in the last car. So we're all on the roller coaster together with whoever our affected person is, our family members, it could even be close friends. So that mental health piece is important for all of us. I think when we talk about adaptation, that can be kind of a tricky thing because we'll often use words like acceptance, radical acceptance, being able to kind of own the situation, be in the present, and then how do we kind of use this energy and move forward? This is all tied in with grief, and I will put a plug in for later on. Today, we'll be talking about this a little bit more. But grief is a huge thing within our community, and it's often griefs that aren't talked about. So many of us, as we said, the roller coaster, we're up, we're down, we're around and around, it's dark, we don't even know where we're going at this point. Those are grief issues. As we're losing pieces of ourselves, if we're not able to have mobility, if we're losing our independence, these are all losses. And for those of us who are caregivers with children, those things like, you know, my son couldn't ride a bike. That was a loss for me because everyone's talking about, you know, my child's riding a bike, oh, he's going over there. So those different kind of losses, I think, impact us, and they're not the ones we talk about. So the disease can be very isolating, and which I think why coming here is fantastic. I think going on to UMDF, finding groups, making sure you have that support system, because again, we have different journeys. No Mito case is the same. We know that. Doesn't matter if you have the same diagnosis. No, it's not the same, but we are kind of on the same ride. So really making sure that we're tapping into that support because that is important for being able to adapt. And that's kind of the key. The word adapt, I think people kind of don't fully get the idea, but that's where we have control. We can control our thoughts. We control our behaviors. We may not be able to control what's around us, but that's what adapting is. It's not liking it. It's not going, okay, this is great, but how do I adapt to it? So with my son, his vision is a huge issue. Okay, so he adapted. We have a huge computer screen for him. We know we have to have a touch screen so he can make it much larger. Does he like to kind of schlep that thing around with him? Not particularly, but we adapted so that he could still go to school. He could still go to college. And often these adaptations may not feel great. Again, I'll use him because he's not here. My other son is here. It would be great if he would use a cane for his vision. He won't. He's just not quite there. And we're trying to help him to understand. Again, that's an adaptation that would clue people in to maybe he might need assistance when he's on a subway or when he's on a train. It would also help him be more independent. So he could walk further. He could do more things. But again, that idea of adapting, we often struggle against it. And I'm going to use an analogy that I'm going to use later. Most people, I think you hear about the undertow on a beach. And whoever's Gen X or boomers, for some reason, we learned about quicksand. I don't know why we learned about quicksand. I never encountered quicksand, but the point would be, we want to struggle. We fight. It's not in our nature as people to give in. But if you're in an undertow, You swim with it. You let it take you. You go parallel. You fight it. You're done. But that's human nature. Quicksand. Again, I don't know why I know this. If I fall in quicksand, if I struggle, I'm going down quicker. If I just stay. But that's so hard to do often. But that's adapting. That's kind of bringing that concept in. How do I use the energy of my feelings? How do I move forward? And again, it can be a struggle and a fight, but that's where the support systems come in. And to validate, that is okay. We are going to have those moments of stages of grief. We're going to deny. We should be angry. We can be depressed. We can be anxious. That's all normal. But having people that you know that you can talk with would be great. And then I'm going to actually pass this to someone because let them demonstrate some humor in.
Pressure. I don't have like a joke or anything. I think for adaptation, you know, we all wear many different hats: mom, dad, sister, wife, husband, not sister, wife. That's a that's a different thing. Sister, comma, wife, not hyphen wife. So we all wear many different hats. And for a lot of us in this room, one of those hats is caregiver, whether it is to an affected child or a spouse, a romantic partner, even maybe your parent. So for this, I'm not really talking to the affected adults. One thing that has really come home to roost in my mind lately is being a caregiver is not the same as being a parent. It is a different life experience. Being a caregiver is not the same as being a spouse. It is a different life experience. It's a different range of emotions. We've talked about a lot of really complex things today, applying for disability benefits, learning about financial planning for somebody with special needs, a lot of drugs, a lot of clinical trials. You hear vocabulary at these things that you have probably never heard in your life, and you have become expert in these things. You didn't go to school for it. You didn't plan for it. You didn't ask to get on the roller coaster ride, but you all have become experts in a lot of really complex things. Give yourselves credit for that and give yourselves the grace to learn the things that you still have to learn, and the forgiveness for not being an expert in the things that you're not an expert in yet. And just remember that being a caregiver is different from being a parent. It is a very different life experience. So it's okay if you need to come places like this to sort of figure out how to navigate these complex things. If, you know, they say parenthood doesn't come with a guidebook, it does. Go to a bookstore. There's 1,000 guidebooks on parenting. Being a parent of a child with special healthcare needs, that doesn't come with a guidebook. You got to talk to the other people who are in the room and figure out what you're supposed to do. And yeah, I mean, humor definitely helps. We've all been laughing a lot up here, especially at Howard and Ann. And I hope you all in the audience have been laughing a little bit too. But, you know, so take those sort of things that help you cope and monopolize on them, you know, really capitalize on them, make the most of them, but just give yourself some grace and understanding and time and get through it.
I can't say anything as profound as what Stacy and Jaci said, although Dr. Goldstein, I am curious about the sildenafil. We'll talk about that offline. So there's my joke. It just came to me. The only be careful. The only thing I want to mention is when it's not just when you have a child with mitochondrial disease, and we tell this to the medical students that we talk to at the University of Pennsylvania every year when they present Mara's case and we answer questions for a couple hours. You're treating a patient, but it's a family situation because it affects the parents who would normally be the caregivers, or if there's other caregivers, it affects the caregivers. And you got to watch out for the signs that a caregiver or a parent is having a problem. In my case, I'm not ashamed to admit that that for the first 3 years of Mara's life, I was angry as hell, and I was angry at the world. And I'm not the person that you see here who's very comfortable in talking about all this stuff. I kept it all in. It affected me at work. It affected my relationship with Ann, and it affected our relationship with our older daughter, Dana. And it took me, and finally, after 3 years, there were a number of people, including a friend of ours who's a pediatrician, who said, you need to get some therapy. If you feel like you're ready to boil over, talk to somebody about it. I went and got therapy. It only took me about 6 weeks before the pilot light went on, and I wasn't doing my daughter any good. I wasn't doing my wife any good. I wasn't doing my other daughter any good. So I learned to compartmentalize things, find a way to deal with the anger. For me, it's doing something physical. I run or walk a lot. I used to punch a heavy bag when I got really angry, but I can't do that anymore. My shoulders won't allow it. And find something that you can do physically that you like to do, and do as much of it as possible. Find something that you like to do to get your mind off of your child's situation, even for a brief period of time, whether it's reading a book, binge watching something on Netflix. There's nothing wrong with doing that to give yourself a break.
Yeah.
I came with a prop today. I didn't name it. It's called a damn it doll. And when you have that physical need, if you can't do a punching bag, works really well. You can yell at it also. So if you really want to yell at Mito, because you can't really yell at Mito, there she is. You can yell, kind of give that.
The original Elmo.
I don't even want to know. I don't want to know that story, Anne. I'm afraid.
I essentially. So let me explain. Howard got angry. I used to like punching. And I used to punch the couch when I was in the early days, very angry. And a couple times I missed. And there's wood frames on couches. So then I learned, take a stuffed animal or take something and just beat it. The other thing that I learned as a child, my father passed away when I was 12 years old. For some reason, he knew I wasn't going to be here, is that you should compartmentalize. If you feel any emotion in any direction that's kind of over the top, set a timer, whether it's 5, 10, 15, 20 minutes, whatever it is. Go somewhere off. Don't hurt yourself. Don't hurt anything. Let it out. When the timer goes off, get up and move on to something else. I used it personally, and I also used to use it in business. And I still do it sometimes when we get frustrated. So that's the only other thing that I can suggest. Certainly we have a social worker that. I'm sorry. Well, I have ESP. There's a question, Margaret. Oh, there's a question.
Oh, no, you can't. We can't hear you unless you're in the microphone. And we're going to have to wrap up in a minute. We're running out of time here.
This is my plug for my best friend, Google. If you at any time are feeling anything that isn't happy, if you Google smiling animals, it'll make you happy. So do that. If you have a friend who's having a hard time, you don't know what to say, smiling animals, everybody can do it right now, and everybody's going to get a big dopamine release.
I vote for everyone looking at smiling animals right now. I think it's good for us. And
Animals. Fainting goats. It is a thing. So for some reason, some goats just faint when they're startled. It is the funniest thing to watch. And they just bounce back like nothing happened. But yes, if you need to have fainting goats.
Well, I want to thank everyone for coming and thanks the amazing panel for all of the amazing things that we learned today. And I want to reiterate that we have time together tomorrow at Coffee and Conversations. It begins at 8:30 in the morning and we'll all be there, and please come and so that we can continue this conversation. This has been enlightening, and thank you again to all of our panelists.